Hello, everyone. While we're waiting for others to join, um, this is session 2. We have the dates and times for session 3 and session 4. Those are also in the Echo portal. And we'll go to the next slide. And if you can scan the QR code, or there's also a link in the chat where you can sign in. And we'll give everyone some time to sign in. Hello and welcome to those of you that have just signed in. Thank you for attending today. We have a QR code on the screen if you could scan to sign in. And we also have a link in the chat if you'd like to use that instead. And then we'll wait a few minutes while we let people sign in. Okay, welcome everyone. We're going to go ahead and get started. Welcome to the Urea Cycle Disorders Echo. This is session 2 of a 4-part series, and this is brought to you today by the National Urea Cycle Disorders Foundation and the Urea Cycle Disorders Consortium. My name is Teresa Warner. I'm a parent of a UCD patient and executive director of NUCDF. Our deputy director is Jill Williams. She's with us today, and she'll be manning the chat. So if you have any questions or tech issues, she'll be able to help with that. At NUCDF, our mission is to save lives and improve outcomes of individuals with urea cycle disorders. We believe that this 4-part series will help us move closer to our goal of rapidly diagnosing, effectively treating, and curing UCDs. Today, the ECHO is supporting CME, and that CME credit is supported by the families of NUCDF. We want to thank you for your commitment and showing up today. We know that this is, for many of us, a holiday week, not just a holiday weekend, so thank you for giving of your time. The QR code that you see on the screen, if you could scan that to sign in. And then there's also a link in the chat. Next slide. This is our agenda for today. We have 5 minutes of introductions and housekeeping, and then we have a 50-minute didactic presentation by Dr. Sandesh Nagamani and Dr. Andrea Gropman. And we'll have 20 minutes for a case study discussion, and then followed by 15 minutes of a group discussion. Next slide, please. Just some housekeeping. If possible, if you could keep your cameras turned on. We know some of you are probably traveling to and from work, but if possible, if you could keep those on. Echo is intended for educational purposes only. We will not have any opportunity to talk about individual personalized cases. Presenters cannot provide any medical advice. And to be able to receive CME credit, please remain in the session and complete the evaluation that you'll see at the end of the presentations today. Next slide. If you could, introduce yourself in the chat. Give us your name, your location, and your specialty. And we'll wait a few minutes as people start to introduce themselves. Those that have just joined, in the chat, we have a link where you can log in via the Echo portal. And now we're introducing ourselves in the chat with your name, your location, and your specialty. Okay, we'll go ahead and get started. Next slide, please. I'd like to introduce our subject area experts for today. We are honored to have Dr. Sandesh Nagamani. He's the professor and vice chair for clinical research in the Department of Molecular and Human Genetics and professor of medicine at Baylor College of Medicine in Houston, Texas. He's an NUCDF fellowship awardee and a medical advisory board member. And most importantly, he is a co-PI for the Urea Cycle Disorders Consortium. Along with Dr. Nagamani, we have Dr. Andrea Gropman. She's the Director of Neurometabolic Translational Research. She's the Mark F. Tamer Endowed Chair in Pediatric Neurology at St. Jude's Children's Research Hospital in Memphis, Tennessee. She's also an NUCDF Medical Advisory Board member and the co-PI of the Urea Cycle Disorders Consortium. So I'm going to turn it over to Dr. Nagamani.
Thank you much, Teresa, for the kind introduction. And again, I'm Sandesh Nagamani, and I'm honored to sort of provide this didactics as a part of the UCD Echo series, along with my friend and colleague, Andrea Gropman. So these are our financial disclosures. I have recent or active research funding with Sanofi, as well as a recent innovations and data exploration and analyses PI research funding from the same company. I've served on the advisory committee of Sanofi in 2021 and on NextCure's preclinical development pipeline for 2024, but none of these are related to the contents of the talk today, so I do not have any relevant financial disclosures for this talk. Dr. Andrea Gropman has a financial disclosure that she's a speaker for Baylor Genetics. So what we thought we would do today was to split the talk into two major parts. I will deal with the first part, which is diagnosis of UCDs, And Dr. Gropman will treat with the second part, which is treatment of UCDs. And each one of those has been divided into subparts. For mine, I will very briefly introduce the UCD. So I'm going to give a 30,000-foot overview of UCDs. And since the main point of my talk is about diagnosis of UCDs, I'm going to review how we make a clinical diagnosis of UCDs, how we make a biochemical diagnosis of UCDs, and then talk about some of the practical aspects of genetic testing or molecular diagnosis of UCDs. Dr. Gropman will then reinforce some of the salient learning points with a couple of vignettes within her series, within her part of the talk, and she will also allude to the general principles of acute hyperammonemia and general principles of long-term treatment. Both of us would be remiss if we did not put in a plug for the next UCD Echo series that are going to tackle in detail about some of the management issues, including dietary management, medication management, transplantation, and emerging therapies, for which this will set the stage. So first, for my part, I'm going to briefly give you an overview of the UCDs, and I do understand that there are individuals with significant expertise on the domain, but some attendees may not be as familiar as the rest, so please bear with us. So again, I'm preaching to the choir. We all know that all living things need nitrogen. Nitrogen is an integral component for many constituents of our bodily functions, proteins of all tissues, nucleic acids, and so on. But all the nitrogen that is incorporated into our body tissues has to come from the food, and none of those that we breathe through the atmosphere gets incorporated into our body tissues. So we get nitrogen either through the food we eat or through the water and this nitrogen, after it has been incorporated into the amino acids and to the proteins, the excess nitrogen has to be excreted. So the excretion of waste nitrogen, one of the main products is ammonia, and ammonia has to be disposed of. And how is that done? Ammonia is poorly soluble, but soluble in water. So if you are an animal that has excessive water that can dilute the amount of nitrogenous waste, then you do not need a special pathway to excrete ammonia. So in many aquatic animals, ammonia can be freely diffused across into the water milieu in which they live. But that presents a problem for all terrestrial animals because we do not have an unlimited source of water to dilute this nitrogenous waste. Thus, we do have metabolic pathways that convert ammonia into more soluble nitrogen-rich compounds. So terrestrial arthropods, lizards, and birds dispose ammonia by conversion to uric acid, while mammals, adult amphibians, and some cartilaginous fish, and we as humans, we're all ureatelic, which means that the primary mechanism by which we dispose of ammonia is by conversion to urea. So how is ammonia converted to urea? This is the classical pathway, the urea cycle, which incidentally was the first cyclical pathway that was discovered in the 1930s by Hans Krebs and Kurt Sleet. This pathway takes ammonia, which is a byproduct of the protein and amino acid metabolism, through a series of steps. So ammonia from the body pool of nitrogen waste is combined with bicarbonate through CPS and locked in as carbamyl phosphate, which then goes through a series of steps, and a second nitrogen is added via aspartate to create arginine, which is then cleaved by the enzyme arginase to produce urea, which is a relatively more soluble nitrogenous waste product. If there is a block in this cycle, by which I mean either in the enzymes depicted here in blue that are required for conversion of nitrogenous waste into urea, or the transporters that are required for the cycling of these intermediates through two compartments, which is the mitochondria and cytosol. There is a block in the disposing of waste nitrogen that accumulates as the toxic ammonia, which is a neurotoxic product. So a deficiency of either the enzymes or the transporters give rise to the primary well-characterized urea cycle disorders. These could be the 6 enzyme deficiencies, which are listed here, or these could be the transporter deficiencies that, in addition to causing the hyperammonemia, has other features. The estimated prevalence I have collated from various sources, and they're likely to be in the realm of what the true prevalence is. OTC deficiency being the most common. The estimated prevalence from the UCDC, when we looked at it, is somewhere around 1 in 50,000, but the range that has been published is between 1 in 14,000 to 70,000. This is the most common urea cycle disorder, to the very rare forms such as the NAGS deficiencies or HHH syndromes, which have a very low prevalence. Now, additionally, as you saw in the cycle, in order to keep the cycle moving, you do need many intermediate compounds. So if you were to have a deficiency in that, either carbonic anhydrase that supplies the bicarbonate, or lysinuric protein intolerance that is required for the cationic amino acid transports, then you have secondary block in ureagenesis as well, leading to hyperammonemia. So now that we know a very brief overview of the nitrogen processing, the synthesis of urea, the components that are required for ureagenesis, and the block that causes hyperammonemia, the second part of the talk is for us to review some of the clinical presentations, or UCDs, as clinicians. How do we make or suspect a diagnosis of UCD in someone presenting to the ER or presenting in the hospital? So the clinical diagnosis of UCDs requires a high degree of suspicion, as some of the manifestation can sort of have an overlap with non-Mendelian sort of presentations, which may include neuropsychiatric disorders, alcohol intoxication, substance abuse, neuropsychiatric manifestations, and so on. With severe defects in the urea cycle, infants, neonates present within the first week of life with a catastrophic illness that presents with hyperammonemia. Children are typically healthy for the first 24 to 36 hours, after which they develop poor suck, vomiting, refusal to feed. They have altered mental status, and if untreated, this may progress rapidly to encephalopathy and coma, which can be fatal when untreated. And many of these children first undergo a sepsis workup, because that is what is in the differential, and children with neonates with sepsis present with those findings. So if you were to encounter somebody in the NICU, or you were to encounter someone who's been sent home within the first week of life with a sepsis rule out, you should keep UCDs in the differential diagnosis. Now, if the defect is not severe, but there's a partial enzymatic defect, they may present later in life. And by later, I mean it may be after the neonatal period, sometime during the infancy, or for the milder forms, even in later childhood or adulthood. These individuals can present with classical hyperammonemia and an encephalopathy very similar to those with severe defects in the urea cycle, but may also present with more subtle symptoms such as protein aversion, behavioral abnormalities, mental status changes. Some UCDs may also present with unique features wherein it might be difficult to identify that this is a presentation of an inborn error of metabolism. For example, individuals with OTC deficiencies can present with frank acute liver failure, with elevated ASTs, ALTs, decreased synthetic capacity of the liver, and coagulopathy. And when you measure ammonia in these individuals, they will be high, but typically, because acute liver failure per se can cause hyperammonemia, many of them are ascribed to the acute liver failure rather than the ureagenesis defect per se. Individuals with ASLD can present with chronic liver disease and hypertension. And finally, individuals with ARG1 deficiency or arginase deficiency can present with spasticity and motor problems and may be diagnosed with cerebral palsy rather than a urea cycle disorder. So clinical diagnosis requires a high degree of suspicion. Suspect UCDs whenever you have a catastrophic presentation that mimics sepsis within the neonatal period. Keep it in the differential whenever you do have encephalopathic presentation, neuropsychiatric manifestations, and sometimes even in acute liver failure, motor problems, spasticity, where UCDs may not be your first differential, may not be on the top of your differential diagnosis. So to reiterate what we have spoken, clinical features that should raise the possibility of UCDs in older children and adults include chronic intermittent vomiting, headaches, lethargy, altered mental status. And if you were to ask the parents of these children or ask adults, what was your diet like? They will often tell you that I did not like to eat a lot of protein. Those made me sick. I always felt dull after eating them. So I learned to self-restrict protein. They may also develop, as I said, frank confusion, disorientation, anxiety, seizures, and may present with frank encephalopathic changes. Again, as a learning point, symptoms of hyperammonemia may mimic psychiatric disorders or drug and alcohol intoxication, and these are often some of the initial diagnoses for adults who present in the ER because the adult ERs are not used to seeing individuals with a Mendelian IEM that have been missed to be diagnosed within the childhood period. This is a slide I stole from Dr. Gropman. She'll reiterate it again during her part of the talk. But as a learning point, if you do find neuropsychiatric manifestations and neurological manifestations, especially those that are intermittent, please do think of an IEM like urea cycle disorders. So now that we know what sort of presentations are suggestive of UCDs, if we do suspect UCDs, what are the biochemical workup that we need to do? So how do we biochemically diagnose the UCDs? The single important diagnostic biochemical marker would be hyperammonemia. It is a hallmark of most UCDs, especially the proximal and the early part of the distal UCDs. And again, I put in a plug to session 1 of the UCD Echo series, where recognition and testing of hyperammonemia were highlighted by Dr. Burridge. And here is the link for you to get to that series. Hyperammonemia, whenever you're looking at ammonia levels, one needs to be cognizant that normal ammonia levels vary by age and laboratory. So when you're looking at these labs, ammonia above the upper limits of normal, especially when associated with clinical features suggestive of UCDs, which we have discussed before, that should really raise a high degree of suspicion for the UCDs. Now, normal ammonia levels can also be seen in other conditions. One of the more common causes for a high ammonia level, especially in the adult world, is that the sampling and processing of the blood was not appropriate. If you go to the first session, you will see how blood has to be sampled and processed. Typically, this has to be ordered on stat. The sample has to be kept on ice and taken immediately to the lab, and the processing has to be done within 30 minutes. And if you keep the sample for long within the wards or in the ER, or it sits out in the lab before it is analyzed, you can get a spuriously high ammonia level. High ammonia is also, of course, seen in UCDs. It can be seen in liver failure or with portosystemic shunts, persistent ductus venosus. It can be seen with certain chemotherapeutic agents such as elasperginase, and also with other inborn errors of metabolism such as organic acidemias or mitochondrial disorders, where the ureagenesis is a secondary defect that leads to hyperammonemia. So once you do have high ammonia, what are the things that one needs to look into? So the first one would be to confirm hyperammonemia. So assess whether the lab draw was done appropriately, assess whether the analysis was done quickly within the 30 minutes, whether there was any hemolysis in the sample that was submitted, and immediately consult metabolic genetics. Now, if your facility does not have metabolic genetics, other specialties such as neurology, general genetics, and others might be the ones to consult. Consult the appropriate services for acute management of hyperammonemia, and consider repeat testing as indicated for both diagnosis and monitoring. If you get a value which is very high, it is more likely to be a true hyperammonemia than just a laboratory error because of sampling error or or analysis error. So the second part would be to determine the cause for hyperammonemia. At least consider routine comprehensive metabolic panel where you will look at the liver function tests and features of coagulopathy if it is secondary to liver function. And again, at the back of your mind, keep that OTCD can present with acute liver failure. Look at acid-base disturbances. Look at the bicarbonate level. Organic acidemias can present with hyperammonemia as well as acidosis. Look at hypoglycemia. There are Mendelian causes of hyperinsulinism that causes hypoglycemia with hyperammonemias. Order plasma amino acid stat. If your hospital does have a facility where it can be run and reported ASAP, that would be the preferable one. Send out labs typically take a few days to report and might not be ideal and might not help in acute management. But in the plasma amino acids, which you run in-house, look at glutamine, which is elevated along with the ammonias, and also look at citrulline and arginine. And in an upcoming slide, I will show which might help you narrow down the potential type of UCD that one might be dealing with. And again, because you're not certain whether the hyperammonemia could be because of an organic acidemia or other disorders, you might want to order acyl carnitine profile, urine organics, and others as your clinical judgment guides you. So what are some of the biochemical hallmarks when you do all of the testing? Again, number one would be hyperammonemia above the upper limits of normal, sometimes many-fold above the upper limits of normal. Glutamine is typically elevated above the upper limits for your laboratory. And in the proximal urea cycle disorders, because of the decrease in flux through this early part of the cycle, the amount of citrulline in the plasma amino acids may be low. So if you have elevated ammonia, glutamine, and low citrulline, it is a lot more indicative of a proximal urea cycle disorders. Now, because carboxyl phosphate, which is in the proximal intermediate, can be shunted to synthesize orotic acid. If there's a block in OTC, you will also have elevation in orotic acid. But if you have a block in NAGS and CPS, typically the orotic acid is not elevated. In the distal urea cycle disorders, just because of the block of the ureagenesis, you might again get the same metabolic signatures of elevated ammonia, elevated glutamine, and decreased urea. But because of where the blockade in the cycle is, you will have increase of the metabolite upstream and decrease in the metabolites downstream. So for example, if it is ASS1 deficiency or citrullinemia, you have citrulline that can be elevated 5 to 10 times of the upper limits of normal. If it is ASL deficiency, you will have citrulline that can be elevated 2 to 5-fold above the normal. And ASA, which is the characteristic signature of this disorder, just upstream of the metabolite, and lower arginine downstream. If you were to have an ARG1 deficiency, you will have arginine that is elevated. So thus, looking at ammonia, glutamine, citrulline, and arginine will help you narrow down some of the potential biochemical signatures of these disorders. So I just kept this for sake of completion and for you to go back on this table. If you were to have ammonia and glutamine elevated with low citrulline, think of a proximal disorder. If you have accompanying orotic acid that's elevated, think of OTCD. Higher citrulline, think of citrullinemia type 1 or ASS1D. Elevated ASA is signature of ASLD, and highly elevated arginine is a signature of ARG1D. And the remaining of these, I have also put some of the biochemical signatures that go along with the diagnoses. So once you have a clinical suspicion, a clinical diagnosis of a potential ureagenesis defect, and you have the biochemical hallmark, how do you confirm a diagnosis? For the distal UCDs, many a times, the typical biochemical features may be sufficient to make the diagnosis per se, but for proximal disorders such as the NAGS deficiency, OTCD, as well as CPS1, confirmatory testing is often required, and many a time such confirmatory testing is also often performed for the distal UCDs. So there are two confirmatory testing modalities. The first one is the enzyme testing, which was historically available, but is not widely used today, and neither is it widely available. So I will not talk much about that. What has supplanted the enzymatic testing is molecular genetic testing, which we're going to talk about in the next section, which is the genetic diagnosis of UCDs. But I really want to stress that treatment of hyperammonemia should not be delayed while further testing is underway to confirm a diagnosis. Thus, when you suspect based on clinical and initial biochemical features, please contact your metabolic service and or appropriate other services who do manage hyperammonemia within your hospital systems. So that brings me to the final part of my talk, which is molecular diagnoses of UCDs. And I'm going to review some practical aspects of the molecular diagnoses. So I want to thank Darwin Ergueta, genetic counselor, who kindly provided these slides to me. And these slides were actually used for another tele-echo series, which is called the osteogenesis imperfecta tele-echo series. And that's another disorder in which I have domain expertise. And I was involved in that tele-echo series. So I do have permission from him to share these slides. So what I'm going to talk about here in this part is to give you a brief information about what types of genetic tests are available for diagnosis of UCDs. And from the bewildering array of tests, which test does one even choose? And if you choose one, what genetic testing labs offer these tests, and how do you order these tests from them? And I'll briefly give you a ISS view of what is the importance of pretest counseling and what samples are needed for molecular genetic testing. Again, these are by themselves detailed topics, and I can go over the nuances of all of those. So I can see the geneticists on the call get mad at me because I've summarized genetic testing into these artificially created two broad categories. And I understand that I will be wrong at some level. But for the sake of brevity, we can classify the relevant genetic testing for UCDs into cytogenetic testing and DNA sequencing testing. Cytogenetic testing, which is karyotype and chromosomal microarray analyses, detect either numerical aberrations in chromosomes, so number problems with chromosomes, or missing or gains of certain regions of the chromosome. So these may be either large microscopic changes, which can be detected by karyotype, or submicroscopic changes that can be detected by chromosome microarray analyses. Typically, cytogenetic testing is not a first-tier testing now relevant to UCDs. However, CMA might be useful for detecting copy number variants in individuals with OTC deficiencies if the sequencing testing were to come back normal. Now, DNA sequencing testing can be Sanger sequencing, which is eponymous with Frederick Sanger, who came up with the technique. Sanger sequencing was the gold standard for sequencing, but has now been supplanted by the massively parallel sequencing technologies. Sanger sequencing is done only when you know the gene that you want to interrogate, and is usually offered either as a single sequencing test or when there are just a handful of genes that needs to be interrogated. Rarely such techniques are being used now in commercial laboratories, and most of them have transitioned to massively parallel sequencing-based tests. So the MPS-based tests have a panel of genes that are relevant to hyperammonemia, and they may test somewhere between 7 to 15 to 50 genes. Panel-based testing for other Mendelian disorders can run to hundreds of genes as well. And so these are the most commonly used tests for molecular diagnosis of UCDs. In individuals who have multi-system complex disorders where you can't just say it is UCD, but you think that this is UCD plus, or you're suspecting that there's more than one Mendelian disorder, then a genome-wide sequencing test, such as either exome sequencing or genome sequencing, would be appropriate because you get a lot more information on many genes that are relevant for Mendelian phenotypes. So finding an appropriate genetic test, there are multiple ways of how you can do. What my colleagues tell me is that the easiest way to do is to just Google it or use one of the AI-based. They'll tell you what tests are available. But if you really want to see the repertoire of tests that are available, Genetic Testing Registry catalogs the available tests across the United States as well as elsewhere. Concert Genetics you have to register for, but allows you to search and compare the genetic tests from various labs as to how many genes are interrogated, which panels contain which genes, and each one has a unique identifier, and also will allow you to sort of get to those sort of websites where you can order those testing. Again, in true disclosure, I'm not preferring one over the other. I'm not suggesting that you use one lab over the other, but if you were to use one of these resources, for example, if you put hyperammonemia panel on Concert Genetics, you get these panel tests that are offered by multiple laboratories, and you can go in and compare what does a panel A from this laboratory, how does it compare to a panel B from an alternative laboratory? And depending on which one you are comfortable with and which your system is set up to order, you can pick one of those panels. So ordering of the genetic testing can either be done through a genetic testing lab portal, which is freely available on the web, or it can be integrated into the electronic medical record system via Epic. In our case, it may be another system in your case, and you are able to order it either via the portal or via the Epic integrated system. So on which samples can genetic testing be ordered? It can be ordered on a buccal sample. Here it involves the patient just swabbing their inside of their cheeks in a pre-existing kit that will be shipped to them, and following the instructions to ship them back to the diagnostic laboratory that will do the testing. Saliva kits are less popular than buccal kits, but are also available by some laboratories with, again, instructions wherein the individual has to fill up this device with their saliva to a required mark and ship it, again, based on the instructions. Blood is an alternative. Blood is probably one of the popular samples on which the testing can be done. The phlebotomy can either be done within the clinic, or it can also be through remote phlebotomy for some of the labs who will actually send a mobile phlebotomist to the homes of the patients to get it done. So the validity of tests on all three, the labs will tell you which one they prefer. Generally speaking, for most of these panel-based tests, whether a buccal swab or a blood, given the depth of reading that they have, they typically do say that the validity of tests are same whether you use one or the other samples. The final two slides I have are before you do the testing, you need to counsel the patient to inform them what the testing will do. It can help confirm a diagnosis. And molecular diagnosis might help inform on the mode of transmission and recurrence likelihood, especially because OTC deficiency is X-linked, and the recurrence rate is different than the remaining, which are all autosomal recessive. It can potentially inform clinical course and severity. There are a few mutations that are known to present with more severe disorders, severe phenotype than some of the milder mutations. And with more genomic therapies becoming available, having a molecular diagnosis could potentially open avenues for some of these clinical trial options for patients with UCDs. And while you're counseling the patients, you also need to talk about the Genetic Information Non-Discrimination Act, wherein GINA will prevent genetic information from being used by medical health insurance companies from denying you coverage, but it does not provide the same protection for the disability and life insurance. It also, the pretest counseling will also help dispel some of the myths about the disorder, tell the family and the patient and the family members that they're not at fault for, quote, passing on a variant within the family. And we also need to discuss about the type of the results that the patients will get, about whether it's going to be positive, negative, and variant of uncertain significance. So several factors are considered in the variant interpretation, including population frequency, functional data, segregation data, and so on. But for practical purposes, if you get a benign or likely benign, that means that the variants are not causal of UCD. If you get an inconclusive report, that becomes harder to counsel, and you might want to explore what this variant actually does, and that's beyond the scope of this talk. But if you do have pathogenic and likely pathogenic variant, they are likely to be causal variants for this, thus confirming a molecular diagnosis. So that ends my part of the talk, and Dr. Gropman, I will let you take it from here and also move your slides if that's okay.
Okay. Great, thanks. Well, thank you to the NUCDF for allowing me to tag team along with Sandesh as he passes the baton. So we can go to the next slide. So, I'm also a neurologist as well as a biochemical geneticist. And so unfortunately, a lot of these presentations that Dr. Nagamani discussed have a neurologic basis. And so I think there are some important clues that I just wanted to reiterate, or some atypical presentations where you may not have all the data, but it should still be in your differential diagnosis. So we'll go through a little of that, and then I'll give broad strokes of treatment, because our next session will focus more specifically on diet and medications, and then long-term management and emerging therapies would be the session after that. So next slide. So first of all, I just wanted to back up a little bit and talk about the brain's response to all this ammonia. So you saw from the slides that Dr. Nagamani showed that if the nitrogen is not processed properly because of a urea cycle defect, where does it go? What happens to it? And what are the consequences? So a lot of that will go into the brain. And so it's very possible that the higher the ammonia concentration in the blood, the higher the ammonia concentration is in the brain, and it can get trapped there. So there's no system to transport it in or out. It just diffuses across its concentration gradient. So that's why we really want to lower the ammonia concentration in the blood, because we don't want it to get into the brain. The brain does not have a urea cycle, so it cannot break down things and divert to other pathways like it can in the periphery. And so that almost all of the ammonia that's extra from the blood can go into the brain. And in the brain, it's not stored as ammonia. It's actually converted into glutamine. And so the brain has an astrocytic glutamine synthetase to try to remove the excess ammonia. So the astrocyte does the bulk of the work in this disorder. So it's not really a neuronal disorder like Alzheimer's or some other neurodegenerative disorders. This is a problem with the astrocyte, and the astrocyte is trying to buffer this extra ammonia to an extent. And so when that system collapses, we get swelling. So first we get swelling on the cellular level, and then we get the brain edema. And many patients have herniated from untreated hyperammonemia, where they've progressed without, either effective treatment or treatment that's delivered quickly enough. So the other problem that we have in the brain is that blood-brain barrier. So in this case, the blood-brain barrier doesn't keep the ammonia out. It may keep drugs out, but it doesn't keep the ammonia out. And so really the brain is, I would say, the first organ to suffer and the last to recover in urea cycle disorders. And that's my quote, so I didn't take it from anywhere. Maybe I'm wrong, but that's been our experience. Next slide. Okay, and so what happens when the astrocytes and then the brain swell? Like, how does that cause the clinical symptoms that we see? Well, there's increased in intracerebral pressure. There's initially increased cerebral blood flow and then decreased blood flow. We have increases in reactive oxygen species, the mitochondria swell, and we activate the NMDA receptor. And so that can trigger excitatory damage. Now, even to this day, we're not sure exactly if it's one mechanism or several mechanisms. So there is energy deficit, especially with the proximal enzymes being in the mitochondria. There's definitely glial cell dysfunction with osmotic disturbances. We can see metabolic disturbances. We can measure those as a proxy by proton spectroscopy. But the question that we still don't know is all the injury due to hyperammonemia and the associated metabolites? Because also some of these intermediaries of the urea cycle can affect the immune system, T and B cell and neuroinflammation. So, but whatever the case is, this is a cascade, and this translates to some of the symptoms that we see in the patients. So next slide. So newborns have different diagnostic levels of ammonia, as Dr. Nagamani had indicated. So the level is not an absolute, it depends upon the age. And so all ammonia is not necessarily a urea cycle disorder. Some may be due to liver failure or other inborn errors of metabolism. And then the adults tend to not have as high an ammonia initially until they decompensate. And so you may see adults have symptoms even with an ammonia of 100, whereas a newborn you may see has an ammonia of 1,000. So the absolute level has to be taken into account when looking at the patient's age, where they are in their disease and their symptoms. So it's hyperammonemia with symptoms. Some patients may have symptoms at 60, some may not till over 100 in the later onset. Next slide. And so again, the urea cycle tends to present with the highest ammonia levels of the inborn errors. unless there's been, decompensation or later on. Sometimes you can get a very high ammonia and neurogenic acidemias. And so this again is showing the hyperammonemia activating these astrocytes to release inflammatory factors as well. So there's inflammation, there's swelling. So many things are going on that are dysregulating the brain under hyperammonemic conditions. Next slide. Okay, so this is my slide. It was stolen. The neurologic presentation varies across the age spectrum. So the neonates may have a very generic response with poor feeding, lethargy, hypotonia. They may have seizures. The seizures may also be subclinical. So now that we have the opportunity, and it's actually protocol in many NICUs to run a bedside video EEG on those infants who are lethargic or encephalopathic, we've been able to see that, yeah, it's not always just the ammonia and the swelling, but some of these infants have seizures that need to also be treated to impact their outcome. The infant and toddler, they may have developmental issues, they may have irritability. The children may present with episodic vomiting, food refusals, behavioral issues, females perhaps with migraines. There may be symptoms around menses. The adolescent, so the adolescent who has acute severe mood changes could be a late onset OTC, for example, encephalopathy of various degrees. And then I think the adults are sometimes the hardest to diagnose, especially those that present with more psychiatric symptoms. And, I say this because in all of these scenarios, the patients may not come to us. The neonates sit in the NICU. It's up to them to really react. The infants may be seen in primary care and be treated for developmental delays. The episodic vomiting, they may be told they have abdominal migraines and sent to neurology. And then certainly the adults with psychosis are probably somewhere in the psychiatric unit, and they're not thinking of these disorders. So we really need to educate our peers also. Next slide. Okay, so here's a couple of vignettes. So this is baby A. This is actually a male baby who on day of life 3 had poor feeding, vomiting, and lethargy. So right now doesn't sound very specific. We can't jump to the conclusion that there's a UCD. However, because the baby was lethargic and because Dr. Nagamani said have a low suspicion for getting that ammonia, it was obtained. And the ammonia level was 540, which is abnormal. They also sent plasma amino acids. And an EEG was run because of the baby's lethargy and showed a burst suppression pattern, which I'll show you, and I'll tell you how we might be able to use the bedside EEG to guesstimate what's happening in terms of ammonia regulation in babies with urea cycle disorder. So the key point is the high ammonia is a red flag because the symptoms are pretty nonspecific otherwise. Next slide. So again, the presentation, you see that with sepsis, cardiac issues, right? Poor feeding, vomiting, lethargy. Next slide. So the ammonia was high. There was a burst suppression pattern. So let's go to the next slide where I think, yep, there it is. Okay. So we actually looked at long-term EEG in neonates with hyperammonemia. And so what we saw is that actually and this is from our work, the ammonia concentration really, can affect brain firing. So the first top EEG, you see some bursts and you see some areas where there's not as much activity going on. And that was with an ammonia level of 97. So, you should have in a neonate, they don't have a mature EEG pattern yet. So you're going to see some bursts of activity, some rest, some bursts. There should always be more activity than these suppressed areas. And then here on the next one, the baby had a higher ammonia and was actually having a focal seizure. So you see that at the bottom. And then the last one, you don't see much neuronal activity at all. So that's the effect of the high ammonia, is it basically shuts down the brain activity. And so if you see something like this in a baby with a known urea cycle disorder, that ammonia is high and you should contact your genetic team. Even if the protocol says check an ammonia every hour, this is a pretty ominous suppressed EEG that requires action. The one above it also requires action because the baby's also having seizures. And so seizures deplete the brain of energy. And since there's already potential energy problems in with hyperammonemia, you really want to make sure that you're treating all the potential causes of the encephalopathy in this baby. Next slide. Okay, so they got plasma amino acids. There was an elevated glutamine. There was a low citrulline, like Dr. Nagamani's chart. The organic acids were unremarkable. Orotic acid was elevated. So going by his chart, this is an OTC male. It was an X-linked disorder. Next slide. Okay, so what if it's a little more vague? So this is Emma, and she had vomiting, pretty frequent vomiting, and was diagnosed as having abdominal migraines. She was also started to have mood swings and hallucinations, which would be unusual for abdominal migraines. And so somebody decided to do an ammonia level, and it was elevated. So the key point here is that the females with OTC also can be symptomatic. I know some of the older teaching was that the majority of them aren't, but their symptoms can be very much different or even subtle, and they can have crises during menses, for example, or infections. So, keep that in mind. When things don't fit with a more common diagnosis, it's probably because it's not the common diagnosis. Next slide. So is this a migraine, or are we missing something? So she had no significant medical history, presented to the emergency room with recurrent vomiting, severe frontal headache, and confusion. So this is Emma getting worse. These episodes had occurred over the past year. Again, she was diagnosed with cyclical vomiting or abdominal migraine, and she'd been treated with antiemetics and sumatriptan and had partial symptom relief. So thinking something else. Well, I already gave you the answer, but we'll keep going. Okay. So the other thing that was concerning was she was becoming more lethargic and had word finding difficulties, and there was really no sign of infection. Her vital signs were fine, but then she started becoming combative, psychotic, drowsy, and disoriented. So this would be very concerning for an individual whose ammonia level may be increasing even as the patient is sitting there in front of us and not being evaluated and treated. And then another specific sign I wanted to point out is that on her neurologic examination, she had what we call asterixis. So for those of you who have taken care of adults with hepatic encephalopathy and you ask them to put their hands out, they have this flapping tremor. And we see that when the ammonia is elevated. So I sometimes tell my patients when they're not sure if they should go to the emergency room is to have them do this to see, what's happening and if there could be some ammonia elevation that would require a visit to the ED. Next slide. So here were her labs. Okay, and they actually did a tap on her. I probably wouldn't have, but at this point she had elevated glutamine and low citrulline. Orotic acid was elevated. And so eventually they looked for a pathogenic variant and found one. Next slide. Okay. The other thing I wanted to point out is that many of these patients would undergo a brain MRI. If someone has headaches, and certainly if they have changes in their level of cognition and they become lethargic or combative, they're going to go for an MRI. And so in the early stages of hyperammonemia, the T1 and T2 weighted sequences may be completely normal, and almost invariably they are early on. However, for those centers that have spectroscopy, some of these changes are very quick. And so this is actually an overlap of 3 different patients. So in the red, we have a patient who was known to have symptomatic OTC. These are all females. And so we see the glutamine. I don't know. I can't point because I don't have control of it, but the other way to the right of my right. Yeah. No. Well, that's okay. So that's one. That's the alpha end of the molecule. There's also the beta end of the molecule. If you go after the NAA peak, go the other way. Keep going, keep going, keep going, keep going, keep going, keep going. Yeah, the other red peak. Okay. So glutamine's elevated, and it wasn't elevated in her sister, who is a carrier and asymptomatic, and the green is the normal control. Then if you go back to the myoinositol, so myoinositol is a signaling molecule and also a buffer for fluid dysregulation. And so in this case, we see an inverse relationship. We see a low myoinositol, the low red, and the individual had the high glutamine. We see a very healthy myoinositol in green for a healthy control. But curiously, in the sister who's supposedly asymptomatic, eats a normal diet, she sort of had an intermediate myoinositol. And then if we go to the choline, choline is a late response once you damage your membranes, and it was low in both. So we actually used this in a patient who had presented a boy with behavioral symptoms that occurred quite frequently, and was told by his physician that he just acted that way when he was sick. His MRI was normal. He had a mildly elevated ammonia at that point, although it increased. But he had a very, very high glutamine peak and low myoinositol. So on that basis, and also got some family history that his mother was vegetarian, self-defined, we presumptively gave him a diagnosis of OTC and started treatment, and then was confirmed later. Next slide. So sometimes the MRI can help you if you have spectroscopy. When the swelling is quite advanced, you'll start to see cortical swelling, and there's a specific pattern. It's more in the insular region, which is the deeper region, the cingulate injury. And then chronically, you may develop some atrophy and white matter loss. So recognizing those patterns early in a patient with so-called migraine who would have imaging could draw you to put that on your differential as well. Next slide. Okay, and then the one that everybody is afraid to miss is the adult. So this is Mr. R, who was 28 years old. He suddenly became confused. He was hallucinating and he was disinhibited, initially diagnosed as psychosis. I would add also, if he had a couple tattoos or, was driving a motorcycle, people may run to conclusions about drug and alcohol as well, and potentially delay life-saving therapy. His ammonia initially wasn't that high. They went through the family history and there was really nothing going on with him, no siblings. This is a recessive disorder, so you may not get any other family history. So even in the absence of anyone else in the family with similar conditions, a patient can still present late onset. Next slide. And then I think the other case that bears some mention is, and this was alluded to by Dr. Nagamani's slides on arginase deficiency, is it cerebral palsy or something else? So cerebral palsy, at least these days, unless there's a clear anoxic injury at birth, and even then, there could be a genetic etiology. We really need to think about whether we're using anchoring bias or whether, there is something else going on. So this was a 7-year-old who was referred for evaluation of progressive lower extremity stiffness, toe walking, and frequent falls. He was diagnosed with spastic diplegic CP at age 3 based on hypertonia and motor delay, but there was really no history to suggest why this would be his diagnosis. There was no prematurity. There was no perinatal hypoxic events or any brain injury. So again, jumping to a conclusion without going back and seeing that there's really no basis for him to have just run-of-the-mill CP, we have to look for something else. The other thing that also doesn't fit is he had early developmental milestones, but started to decline at age 3. So a regression at age 3 would be highly atypical for someone who had a birth injury and developed CP. But, as time went on, he progressed. And again, CP is not a progressive disorder. It's a static injury. Next slide. So his MRI actually showed some hyperintensities in the cortical spinal tracts and involving the periventricular white matter. So it can look like CP, but luckily they got a spectroscopy, and this time we saw another peak. We saw a guanidino compound elevated at 3.8, and then his amino acids really clinched the diagnosis with his elevated arginine level, leading them to go on and confirm his diagnosis, where he did have a variant in the biallelic pathogenic variants in the gene. So again, if something doesn't seem like CP, it's probably not, and you have to investigate another etiology. Next slide. And then I think this is the last vignette before the treatment, is acute psychosis, catatonia, and mania, which are often misdiagnosed as schizophrenia or bipolar. If there's a new onset psychiatric illness, if the patient's not responding to medications that would typically control this or getting worse. I've seen patients with bipolar be put on valproic acid and actually get worse because that can increase your ammonia. And there's no family history. you should always have a low threshold to check the ammonia in these cases as well, because we have had several adults who have presented with this manifestation. Next slide. Okay, so how do we treat these folks? So again, this is the high level. We're not giving, personalized medical advice. So basically, you want to get rid of that ammonia. So you want to get rid of the ammonia they take in and also deal with the ammonia that's already in their system. And so the quickest way to get rid of ammonia that's in the blood is bulk removal by dialysis, also scavengers, arginine to try to push the cycle. Long term, you're going to have a separate talk about that, and that's decreasing the protein in the diet, and you do have to supplement calories and give them essential amino acids. For some disorders, carboglue may be used, like for NAGS. Gene-based therapies, again, we're not going to talk about that in this session. But the other thing is that you have to rehabilitate them cognitively. If a patient has had a severe neurologic devastation from their hyperammonemia, providing them supports, whether it's be speech therapy or occupational or physical therapy, and really being cautious with any medications, particularly medications used for psychiatric indications, and making sure that if the patient has another illness, for example, if somebody wants to put them on steroids or they have a seizure disorder, that you really make sure that the medications can be safely consumed by that individual given their metabolic defects. So we don't treat them in a vacuum, because these patients may have other medical concerns other than just their urea cycle disorder, which may require them to take other medications from time to time. Next slide. Okay, so the goal of the acute crisis is to rapidly lower the ammonia because you want to prevent that brain injury. Many of them will have to go to the ICU if it's significant hyperammonemia. You want to stop all the protein intake, so that's one way of stopping the nitrogen. Provide calories, though, so you want to give high dose glucose and lipids to prevent catabolism, or they can continue to break down proteins in their body, such as muscle, and increase their ammonia load. You want to give them nitrogen scavengers so that you can divert the ammonia, the nitrogens from the ammonia, to compounds that can be excreted in the urine and are less toxic. You want to give L-arginine or L-citrulline. Arginine's IV, citrulline is PO, although somebody at Baylor is trying to develop an IV version. Hemodialysis or CRTT may be needed, especially if there's rapid deterioration or the ammonia is very high. And you want to continue to monitor the labs in real time because things change quickly. And then neuroprotection. So EEG, seizure monitoring, cooling if severe, although there are complications with that. I'm not recommending that be done in these cases necessarily. Next slide. Okay, so here's the algorithm for those of you who like it in a diagram format. So the main thing is to manage the nitrogen. So stopping what goes in and dealing with what's already there by removing it. Next slide. The chronic long-term, again, this will be another lecture, is to balance catabolism and ammonia control and optimizing growth and development. So the diet plays a very important role here, as well as supplements with essential amino acids and vitamins and minerals and trace minerals as well. So the protein restricted diet will be customized to the patient and guided by the metabolic dietitian, because not everybody's protein tolerance will be the same. There may be a sick day prescription as well. Essential amino acids, chronic nitrogen scavengers, and frequent monitoring as well. So once the patient is out of crisis and they're on long-term management, they still require monitoring and adjustment, especially for younger children who are growing, who will need changes in calories and possibly nitrogen or protein status as time goes on. And so again, that will be the next echo session. And then I think the other important things are the family education and emergency protocol. So when all this is happening, it's very scary to the families, and they wonder, how am I going to manage this? What if this happens again? And I think, explaining to them everything about the disorder, about the acute management, the long-term management, and having an emergency protocol. So if this happens again, if they're traveling, you don't want to leave any of this to chance. If you're out in a state park in the middle of nowhere and they've never even heard of this disorder, you really want to give them a contact number where they could call you or whoever's covering for you. You want some basic starting points for those physicians in terms of, what labs they should send, what fluids they may not have or probably won't have scavengers there. And then also think about where they could go. If the patient is vacationing in X, where's the nearest metabolic center, and try to contact somebody there just in case and have a mechanism to transport that patient there if they were to become sick as well. And making sure that they have their formulas and their medications, and if they need any notes for TSA and air travel. So I think you really just have to be prepared. Hopefully nothing happens, but in the event that there is decompensation, you've at least laid out a plan. And then again, long-term management with liver transplant or other emerging therapies will be discussed in the next 2 sessions from now. Next slide. So to summarize some pearls for neurologists and psychiatrists is it's really easy to get pneumonia. Most hospitals will be able to do it. You don't need specialized labs. So if there is encephalopathy or a psychiatric crisis and you're not sure, just get it. The neurologic injury can be cumulative to some extent. It may be preventable if you act early. And certainly if it's on your differential. Neuroimaging plus metabolic profiling can be essential in making the diagnosis, and earlier diagnosis often leads to a better outcome. We just want to draw your attention to 2 upcoming urea cycle events. So one is a virtual family conference, and Teresa can give you more information about that. The other is our satellite symposium at the ICIEM meeting in Kyoto in September. So we'll offer global perspectives in research and management of urea cycle disorders coming from broadly from experts across all the continents.
And we've, thank you, Dr. Gropman and Dr. Naganami. We've added the links to both of these events in the chat. And we'll be able to take probably about 15 minutes remaining in our session. Dr. Naganami will facilitate if we have anyone that would like to present a case, or if you have any questions on a potential case, or even questions about the presentation so far.